Well, thank you very much for being with us this afternoon. This is a very mixed panel with a variety of what I might call kind of provocative and alternative and innovative approaches to bringing more healthcare products to more patients than we have in the prior 40 years that we've been investing in and pursuing biotech. So I'm Barbara Handelin. I'm a geneticist. I'm the purveyor of rare diseases since my training in the mid-'80s. I joined one of the very first biotech companies, Integrated Genetics, which became Genzyme Genetics. Some of you may have invested in Genzyme, but especially as a public company. I was among a small group of early molecular geneticists who said, "Hey, we're going to really completely reinvent medicine from the ground up. I mean, as soon as we understand the genome, we'll be able to define every disease from its molecular origins, and then for sure we'll be able to treat it much more intelligently and effectively." And we set about to do that. And we did that with the help of early venture capital, who came in looking for an exciting opportunity to make the kinds of returns that venture capital had been making in communications, early software, computers, the other tech industry. Biotech was a new word. And so they funded a lot of dreams, and some of those dreams came true. And we have the panoply of new therapies that have been developed and come all the way to the market over the last 40 years. I was a part of that revolution. And about 10 years ago, one of my longtime colleagues, who was actually my PhD mentor, and with who founded Integrated Genetics and other companies along the way, we sat down one day and looked at a pile of ideas, a pile of not just ideas but data, as was emphasized in the prior panel. We looked at a pile of data of projects and even companies that had been left aside, not because the science wouldn't produce great, effective medicine in one way or another, but because that data failed to make it through the eye of the needle of the sources of capital to fund our industry. We've been using the same capital structure since the early 80s to today, all the way through, after the first biotech companies became public, so all the way through the public markets. And that source of capital, as everybody in this room knows, it's an expensive source of capital. And venture capitalists are very delighted to tell entrepreneurs like myself, you shouldn't take our money unless you're really confident, because it's the most expensive capital on the planet. And that is true. And that is why we only have ways to diagnose, prevent, or treat about 10% of all human disease. 10%.
You're generous.
Yes, I'm generous. But everybody should take a minute to say, can that really be true? Just ask yourself if you know anybody in your own personal network who has had a condition that that took forever to get diagnosed, or when it was diagnosed, it had very poor treatment options, failed those treatments, and or who were debt crushed by paying for those diagnostics and treatments. Pretty much everybody I've ever asked that question to says, well, yes, obviously, yes. So that gives you a grounding for understanding why myself an entrepreneur for a long time on the science side, decided with a group of colleagues to turn our attention to innovating on the finance side so that we could assure that the next generation, because I won't be doing this for more than about another decade, so that the next generation of entrepreneurs and scientists, inventors, and business people can create perhaps a new industry where we don't require medicine to deliver the highest kinds of returns for investors. There are lots of places to make those returns, we posit, and therefore let's think about how we can build a new channel. So that's the business of my nonprofit corporation here in California, an epicenter of innovation, and I'm hoping now to be the epicenter of innovation in finance. We call ourselves the 90-10 Institute for the reasons that now you understand. I am moderating this panel again with great pleasure to bring in the perspectives of some people like Norm Friedland, with whom I have done a lot of work over the last 5 years in thinking about how we can marshal more purpose-driven, mission-driven, mission-aligned capital who also want to support the development of good old American companies that thrive and provide jobs and provide affordable medicine. So with that laying the stage for that, I'm going to ask the panelists. I'm just going to say the order in which I want to proceed. Patrick, I'm going to ask you to go first, and I'm going to ask all our panelists to introduce themselves. We'll go from Patrick to you, Mehran. Forgive me if I just mispronounced your name. And then to John, and then lastly to Norm. Right.
Great.
Take it away. Thanks, Patrick.
Good afternoon, everyone. Hear me okay, I hope. But anyway, thank you very much. So I'm a little bit naked here because I'm a physician without slides. But nonetheless, I'll try very hard to at least tell you the story that I bring here today. My name is Patrick Maguire. I'm a consultant. I have a background in medicine, surgery, as well as business. And I've been CEO of 3 companies, all of which were acquired. And so now I'm just out there looking for jobs in the countryside, deciding what gene pool I want to jump into next. But nonetheless, my task today was just to tell you, my perception and what I hear from my colleagues about private equity markets and where are the opportunities to make some money, with all due respect, and make some patients better at the same time. So I took a look at the private equity markets in focus, and really the returns are around 1 to 3%, that type of thing. Not many of which will not get a venture capitalist terribly excited, but nonetheless, you say, well, okay, how can we turn this around to where we both grow the return as well as grow patients to get better? And really the answer, as was found also by the private equity groups, was artificial intelligence. Now, that used to be something that I could spell, but didn't know too much about. I know a little bit more about it now. But the key thing here is, especially with regard to medicine, is where are the cost excesses? Where can you trim and still have an efficient system? And where can you deliver results to the patients? It turns out artificial intelligence is one of those, by virtue of the fact of having more efficient clinical trial and actually using it to get a better group of patients that you really could profit from the treatment. If you took a look at the New England Journal of Medicine about a month ago, you saw that there was a group, there was an artificial intelligence system that was out in play that actually reviewed patient results. And they actually beat a panel of 60 doctors significantly. Now, that's not saying that all doctors should just hang it up and maybe go to plumbing school, but nonetheless, there's something there, I guess is the point. And there's something there just by virtue of getting better results, yes, but also there's something there for efficiencies. And the other thing that they identified was the inefficiencies of the system, much as I faced, because I used to run a pharmaceutical company, was in the clinical trial process, the costs, the time, the people. That's where many of the costs are today. And also what investors and entrepreneurs are facing. They've got to raise more capital to get larger trials because they can't really come to the idea of what is going to be a significant result. Well, there have been a couple of interesting events that have happened. Number one, the FDA seems to be wanting to collaborate. That was always used to be a scary term to me, that the FDA wants to collaborate with you. But nonetheless, that's probably true. That's changed significantly, such that it's led to fewer large trials, more efficient endpoints that can be harnessed earlier, and that can then get better, shall we say, metrics of return on investment if you look at it in slightly the longer term. And people say, well, gee, when is this drug coming back out? Well, when the trial finishes. Well, what's next? Well, it's another 1.5 years of review of the clinical data. Well, for many families, as we're hearing, 1.5 years seems to be too long. So my point is that the private equity market results, actually, they're getting into this space quite, according to the data. About 51% of private equity firms are actually looking at clinical trial efficiencies and looking to get into artificial intelligence to upregulate, speed up the clinical trial results. Artificial intelligence, many people are worried about, is just going to be an inefficient process. Well, it turns out that really the efficiencies are there, and that actually there's not only efficiencies, but there's less cost if you map it out. In addition to less cost, there's more return on investment. So my goal today really was not so much to give you tons of data, especially after lunch, which, many people, I used to feed my board a lot of pasta around lunchtime, especially if I had a tough business decision to make, but so they would kind of nod off a bit. But nonetheless, my goal here was to tell you that artificial intelligence is really nothing to be scared about, but actually there are efficiencies there that can drive improvements in cost and return on investment. And that's what people are seeing when they map this out going forward. I've worked, just so people know, background in case you have questions. I started out in medical school, and then took a left-hand turn and went into cardiovascular surgery. And then after that, I went to business school, and I've been with 3 or 4 companies since then. So that's kind of my pedigree background, things that I know, things that I don't know too well. But interestingly, a lot of companies are coming to the realization that they can move with more efficiency if they actually look at where can we get a clinical trial design and endpoints and statistics that are actually going to make sense to get a result sooner. And I think that's the basic bottom line that I wanted to leave you folks with. I apologize I didn't regale you with a lot of pictures of medical things from the Merck manual and the like, but at least you understand now, at least I think, where the business community is heading and where the opportunities are. So there are opportunities for increased investment, opportunities for increased growth, and opportunities for improvement in return on investment going forward. So with that, I will stop and let the rest of the panel move along.
Look at that, you had 25 seconds left.
Oh.
Thank you, Patrick. And I'm going to ask that we probably wait till the end, Marty, if that's okay, for Q&A, because I think maybe we'll have some
Sure.
back and forth.
Sure.
But thanks for reminding us about the tremendous value that we hope will be harnessed with much more, with a greater embracing of, let's use all the data that we have to look across a much broader swath of the population and to help us to be smarter and leaner. The big consulting firms have been telling big pharma for most of my career that they had to get way more efficient and leaner about how they do their R&D, and they've been pretty resistant to that. Yeah. until very recently. So I think you're pointing to some really hopeful developments. Okay, it's back to you.
Okay, I think I introduced myself. I happen.
All the people online as well?
Pardon me?
Everybody, Norm and John.
Yeah, in turn. Yep.
Now, I'm going to be brief, so you can have a lot of that time. I happen to be a counterpart of what Dr. Maguire used to do. I'm an interventional cardiologist. My input towards what you're saying is you both have said it very eloquently. It makes sense. I just want to remind everybody, AI is not necessarily cheap now. Remember, they started as a nonprofit, and there's a lot of money being poured in AI also because they think they're going to make money. And it's a very interesting philosophical conversation, because the initial thoughts about it was that it is such a powerful tool that it ought to be available to masses because it solves all these issues. And the visionary who actually started was none other than Elon Musk, but he pulled out when he realized they're being commercialized. But then you can understand part of the reason they needed to be commercialized, because AI itself, at least for now, requires a tremendous amount of resources. It's not cheap. So perhaps what needs to be done for the medical community to be able to rescue some of these ideas. There are many good ideas that have come and unfortunately have not come to the market. Because the idea alone is not enough. There's so many other things that have to happen. So what the AI industry appears to have decided to do is they are doing a hybrid, in that they're saying, we're going to monetize it, but then we will make, by monetizing it, because we need those monies to develop it, we will also make it available to people who can't afford it. And we're talking about devices, drugs, agents, ideas that are fantastic, but for a variety of reasons have come and have not come to the market. Perhaps the 90-10 Institute will also look into things that they can make money from, where they can put that money in the less profitable stuff. It's a very exciting time. Obviously, artificial intelligence has tremendous potential, and we're just beginning to understand it ourselves. I will just add that in addition to artificial intelligence, people like you who apply human intelligence are going to make the difference.
Yeah.
That is my 2 cents.
Yeah, that's your 2 cents. Well, great. Well, thank you. Okay, John Cataldi, I think we go to you next.
Well, I certainly appreciate it, and I apologize in advance. Made best efforts to get out to the West Coast. But first and foremost, I want to give a huge round of thanks and applause to Marty for putting all of this together. I've known Marty for a number of years now, and if everybody just take a second and just say thank you to him. This type of innovation with family offices, I've seen most collaborative has been under Marty's care and passion. But about myself, I'm most notably known for advancing tribal rights under the Native American Venture Fund. We work with federally recognized tribes across the United States. I was the prior CEO for the Seminole Tribe of Florida. And what the Native American Venture Fund has done, and an example of which is our portfolio company, Clear Health Pass, is to leverage tribal sovereignty to be able to bypass a lot of the red tape and get access to both innovation, technology, government funding that wouldn't be otherwise available unless playing that tribal card in those legislative set-asides. So in light of so as a portfolio example, and just giving a very high level example, one of the biggest issues I see in healthcare today is that of prevention and early detection, and the inability for our market to be able to address that in a way that is non-invasive and easy, especially having equitable access to, has led to 50% of all US deaths and 80% of injuries in the United States. Medical misdiagnosis of 33%, preventable mortality of 50%, cardiovascular disease risk between 33 and 50%, and not even to mention as far as the mental health disparities that we see in the marketplace today. So by leveraging again that within tribal sovereignty, we're able to have a guarantee of government contracts, government grants, and funding, especially when working with Native American tribes that goes beyond just that of the reservation, which Native American tribes only make 1% of the reservation. And putting that more into terms that's easily understood, all the business rules still apply. We still have to have good business acumen. We still have to be disruptive, but we just add that much more in being able to fast track. And probably the, a real world example was what we're looking to do from a standpoint of a cancer testing using saliva as opposed to poop or, fecal. Exact Sciences came up with a test that you, in essence, poop in a bucket, and you send that into the lab for evaluation. It has a 70% miss rate, even though insurance covers it. Through saliva, a lot less messy, has a 90% plus hit rate. But by leveraging tribal sovereignty, our cost and efficiency of suppliers, it goes in half. The laboratory networks by which we put our R&D through and work with the FDA goes from 2 years to 120 days from as far as concept to implementation in their lab developed test. And the amount of partners and partnerships as this being an ESG and profitable model go through the roof. So it's just an alternative strategy that allows others to, in essence, expand what they currently have beyond the current parameters by which we bucket healthcare today. Thank you.
Right. Thank you very much, John. I would like to next then give the floor to Norm Friedland. Norm, are you ready?
Yes. Is the audio adequate?
Yeah.
Great.
We can hear you great.
Okay, Marty, ditto to what John has said. Following Alex and Tony and Martin and Dr. Crisandi and Patrick and John is not trivial, and presenting before Mark and the other John and Deborah is also not trivial. Not a trivial challenge. As you are wondering, and as Dr. Handelin has told us, matters of philanthropic and mission fundings for healthcare is relevant for a couple of reasons. Number one, health doesn't check your FICO score. Unfortunately, everyone knows someone, a family, friend, neighbor, business associate who has a catastrophic disease. Number two, as you've heard and will hear, near-term solutions for global diseases, cancer, cardio, neuro, ophthalmic, infectious, are here today. It's not science fiction. It's not decades away. And as Marty Tenenbaum, who's in the room with you today, an AI expert, founder of Cancer Commons and XCures, can tell you, the cost of drug discovery, the cost of clinical trials, the cost of bringing a solution to a patient can be reduced by factors of 100x and accelerated from decades to years. So while you're hearing about philanthropic mission capital, what we call ROM, via our model, we're combining traditional market rate investments with mission capital to deliver both solutions and necessary market rate investment returns with dramatically reduced risk. So in my remaining couple of minutes, let me make 4 points. Number one, is there a slide, Gabe, that you can put up? Okay.
Yeah, absolutely.
All right, so this slide will show you what I lived with as a 5-year-old. It was an image of hundreds of.
Norm, hang on just a second, because we're not seeing us slides yet. Gabe, are you sharing your screen?
Yeah, give me just one moment.
Or are you able to share your screen is really what I meant.
And
He has to open the slide and then he has to share it.
There we go.
You're also on
coming.
mute.
Okay, so as a 5-year-old, this is what I saw on a regular basis. When you got polio, you're going to spend the rest of your life in an iron lung. Boom, 1955, one shot, a vaccine, you were never going to get polio again. The funding for this solution didn't come from government, didn't come from pharma, didn't come from foundations. It came from the March of Dimes. Every kid got a booklet, you collected 10 dimes, put them in a pamphlet, and took it to the post office. Number 2, fast forward 70 years. Thanks to Wall Street, venture capitalists, foundations, brilliant scientists, research has given us unimaginable knowledge about human disease solutions. And I know this from personal experience. Do you have the second slide, Gabe? Mission funding, together with ROI, enabled my wife to dance at our son's wedding. It's real. It was genomic expressions 1 ROA test that we took to Sloan Kettering. They matched us with the Loxo Therapeutic Company, and there it was, 5 years of treatment and cure. So this is real. It's real for me, and the challenge is how do we bring this how do we bring this precision and affordable solutions to tens of millions of people? And by the way, every cancer is a rare disease. The March of Dimes strategy, as Alex Silver has said, isn't going to work. We're going to need quantum capital. And that capital has to be a combination of institutional investment dollars with at-scale return on mission fundings. And that's really the thesis of what Dr. Handelin has said and of the 9010 Institute. And a shout out to John Parker of Spring Hood Ventures, who is really a pioneer in foundation philanthropic capital. And what we've developed for FullSky is a model that allows you to check all the boxes: due diligence, scientific validation, financial engineering, tax and legal compliance, for at-scale return on mission capital to be brought to the table alongside traditional ROI fundings. So my last point, my 4th point, is 2 asks. Get to know us, get to know the family offices that are interested and have expertise in these issues. More importantly, get to know the companies on these panels. They can change the world. They can change patient experiences today with a combination of the mission capital and the ROI capital they're looking for. The second ask, consider how your expertise, your networks, your influence can support and drive collective decisions and actions by asset owners to make mission funding decisions for disease solutions, either individually or as a portfolio, via a sensible ROM, ROI capital stack. Finally, let me give an introduction to Marty Tenenbaum, who's there with you, whose Cancer Commons platform is available at no cost for patients with advanced cancer, and to Lisa Woodward for a 2-minute video on the impact of ROM, ROI funding for children with otherwise untreatable brain cancers. Thank you, Barbara. Thank you, Marty. Thank you for the panel.
Lisa, would you like to come up to use my microphone just to introduce your video that I hope is getting loaded up?
Absolutely. Thank you. Michael Bellis is outside the room doing that. Just real quick, I'm Lisa Ward. I'm a mom of a son who looked a lot like the son shown. He was headed to law school and he had a little bit of peripheral vision, double vision. And in a neurologist's office, we heard incurable, inoperable, terminal. And he said, "How long do I have to live?" And the doctor said, "Well, we're going to try a few things, the standard of care." And he said, no. My mom would not have brought me to anyone but the best. I know you know, and I need to know. And the doctor said 6 to 9 months. And he said, I'm not afraid to die. I'm afraid not to make an impact before I do. And I say that because we still get those days, right? We still get the days to make changes and involve our mission with our investment. I used to count the dollars in my retirement accounts until I couldn't count the days with my son. But with Cancer Commons and Senolysis, we're changing the script for hundreds of children that have a deadly tumor in their brainstem. And I'm so honored to be here because the technologies of bringing AI to patient-provided information, to the collaboration with our best doctors and academic institutions is making a huge difference. And when we bring in companies with novel ideas, we can change the course. But everything you've heard these panelists say about the death valley of funding could not be more real in this terminal condition for children. So I wanted to show you in this video real life examples that when you invest in biotech, you can't always see. But when you do it in connection with an advocacy community, you get to see what the patients think. And you get to invest in things that are winning fast and divest of things that are failing fast. There's real advantage of the partnerships that Cancer Commons are able to do with community because we know what we need. So take a look, and I'll be around tonight if you have any questions. Thanks for the opportunity.
Roll video.
We do need some sound. And just a rewind and then sound.
I'm afraid the audio extension is not downloaded without a password, but hopefully it's okay with the closed captions.
Why don't you go help?
Yes, I will.
Download an audio.
100%.
Okay. And while she's doing that, Marty, how much time do we have left?
It's got about 10, 15 minutes.
10, 15 minutes, great. That's what I was hoping for. So if I could, Marty, Marty Tenenbaum, would you like to come up and make some comments and then I'd like to take questions.
Hi, everybody. I'm the founder of Cancer Commons. You've heard that a few times. I started this organization after I survived metastatic melanoma to my liver, and that was 25 years ago. I was given 9 months to live. And I first had no options because all the local oncologists said there was nothing more that could be done. And then I went to the National Cancer Institute in Washington, and they introduced me to these amazing physician scientists. We're at a whole nother level. And then I had a different problem. Everyone said the prognosis was dire, but you could try maybe this thing or that thing, and then I didn't know what to choose. And every cancer patient who has exhausted the standard of care has that. And I started Cancer Commons in order to be able to help that. And I am an AI expert. I'm a fellow of the AAAI, which is the main professional society. And I've taken my life and just pivoted around this. The key idea that needs to be understood is that trials are the most expensive part of bringing a drug to market. And trials are the gold standard. But they are much too expensive and much too time consuming in a disease where every patient is unique. So we heard that cancer is a lot of rare diseases. It's thousands of rare diseases. And we've got to tightly integrate clinical research and clinical care. They're not two different worlds, trials and care. They're one thing where you're continuously learning from every patient. And that data, which is generated in the course of helping patients, is what we can use to make significant to make much more de-risked investments. That's the innovation idea that Norm and I and Barbara and others are working toward, which is to make basically legal insider information. So you raise capital from a new pool, which is family offices, and you invest that based on data of people trying things, handfuls of people. And when you see something that's working, you double down on those things. That's the big idea.
Thanks. Well said. Are we good now? Okay, roll it.
Hi, I'm Brittany Sleeth. I'm Vivian's mom. This is very difficult. Go. Woo!
And do you love to be active?
Yes.
Do you think anything has changed since you've been diagnosed? Do you think the treatment's working? Maybe. What do you want to do when you grow up?
Police.
A police? And what else?
19 months post-diagnosis.
Get fired? What else?
And she's still thriving.
Goes out in the wild and see if anything burns.
If anything's burnt, it's like a firefighter?
And my specialty in the clinic and in my lab is in the study of DIPG and DMG. We are up against a tumor that has a lot of difficult features to beat. It is in a part of the brain that you cannot operate on. It's in a developing brain that has lots of really important developing components. And we're up against the blood-brain barrier, which makes it so that over 90% of drugs that are developed for cancers aren't able to reach it. So we're looking for treatments that are unique and also non-toxic, non-tough on our children and their growing brains. When I first heard of the growing field of focused ultrasound for DIPG, it immediately grabbed my attention. This is a unique method of getting after these tumors that uses sonalescence therapy to target the tumor. Is one of the most promising therapies that we have available for our children with DIPG. Many of my patients are actively considering this as this is a really important time to get behind a therapy like focused ultrasound and the sonalescence based therapy for the tumor, so that we can really have our best chance to make a good progress.
Okay, and how many treatments have you done with sonalescence?
One.
Yeah, just one. When's our next one?
What is the name of your cancer?
DIPG.
And do you remember the things that you did before your cancer?
I made obstacle courses downstairs, and I played soccer, and I ran and jumped.
And after that?
I went to the hospital for a couple weeks, and then when I got out, I had to use a wheelchair.
So after starting your trial, has anything changed?
Now I can run a little bit and do squats.
What were your symptoms?
Numbness on this side of the face.
Okay.
And instability in walking.
Sure.
Yeah, and more close to the diagnosis, slurred speech.
Yeah.
From the perspective of my family members, they say I sounded like a zombie.
Yeah. And what trial are you talking about?
Sonalescence in Washington, D.C.
Fantastic, and they're doing a great job.
Did you receive any radiation for your diagnosis?
Yes, I received 30 treatments of radiation, I think 11 days after I
Stop this one.
Yeah.
Technology at its finest. I'll just briefly tell you, in DIPG and DMG, which we now know is on into adults, it just hadn't been screened before. So 40, 35-year-olds getting the same thing. My son was 20. There has never been a treatment that has impacted more than 20% for a period of time. This is actually the first treatment that I can tell you, even though it's not published, reported yet, I know all 9 of the patients treated because our community is that close, and you would be when you're looking at your child's life. You would want to find anything you could find. So 7 out of 9 of the patients are stable or significantly improving. And there's just not a monetary value I can place on that. But what we know is this is a heterogeneous tumor. This is the type of a treatment that we need to get behind for other types. And this isn't the only one. And it is going to take mission-driven investments in treatments like this for rare disease, but that doesn't mean that's the only thing they'll be able to treat. We just have to de-risk those early investments. And when we do it with community input, with something like Cancer Commons, where patients are providing their data, we've been able to put together 250 patient records in a very short time in a model called XCures, a sister company with Cancer Commons. And our best doctors across the country do not have that many records in any one place, including government databases. And where they exist, it's so difficult to share with industry that even wants to look in to make a difference can't find the information they need unless they're working with a system like this. So we would be honored to share more ideas. Cancer Moonshot has shouted out about our work. And I understand that in this community, we're leading the way in pediatric cancer now. And it's only out of necessity because DIPG won't wait.
Is there a question from John Cataldi? John?
Actually, I just wanted to comment on that. That was beyond powerful and moving. You know, and it comes to investment into what you're talking about and the future of healthcare. I was happy to see when the federal government passed the Right to Try Act, which allows non-FDA approval for potential end-of-life therapies that would allow, in essence, the type of procedures that your child underwent, but more so from an investment aspect, the data that is received from those trials is multi-purpose. There's buckets of data and so much research out there going back to AI that could bring that together. And it really comes to AI and all these great technologies needs to have the human data in order to attach to. So even though it may not appear initially that from a venture capital investment or any type of venture investment that it would have, you know, instantaneous gold, we find a lot of times, and even a lot of our testing, that there's been so many mothballed research and data out there. Once they're linked together, it unlocks amazing amount of potential, and God bless as far as hopefully a quick recovery and that the proof of this therapy may lead to help well beyond just the treatment of this specific illness.
Mhm. Do we have other online questions, Marty?
No.
Okay.
I think that, you know, a lot of people, you know, so I want to have a couple questions for Cataldi, if that's possible. So John.
Oh, sure.
Can you talk, maybe I might repeat my question, but can you talk a little bit about the breadth of what, you know, you can do from a tribal point of view in terms of accelerating testing and distributing products?
Well, from a tribal and testing, and that's, I would love to talk more on the cancer front as well. Unfortunately, Native American people in general are about 5 to 7 times more likely based upon their initial immune system or genomic immune system as far as links to cancer and diabetes, and just from a change of environment over generations, which makes them more susceptible to both disease and chronic conditions and cancers. What we've been able to do is be able to fast track. There's a caretaking agreement between tribes and the federal government in which we're not holden to state law. We're not holden to a lot of federal regulations as well. And we're invited as a sovereign class or as a domestic sovereign to participate in guiding legislation that doesn't just affect the reservation, but actually allows the reservation to affect laws into its favor to help those off the reservation as well. And as an example, we had an issue with EUA and we need to get clarity from HHS. EUA is emergency when COVID was prevalent, or still is, but had to be under EUA. We needed clarification from the FDA on getting access to certain data and moving things forward. Usually that time frame takes anywhere from 3, 6, 9, 12 months. A lot of people don't even have their EUAs. Our response came less than 30 days. They have to respond to us in 30 and fast track us to a consultancy meeting within 45 to 60 days. We have a representative in every branch of government. So, and there's set aside pools for both funding and for federal contracts under the Buy Indian Act. So our time to take a test from, again, concept to fruition on a pre-detection test could be range anywhere. That includes clinicals and includes clinical performance testing, is roughly 120 days versus a 510K of 2 years. That's also because we're under the CLIA Amendments Act as well as lab developed tests. And lastly, the government has an entire spending, I say spending, but has a resource of anybody that does business with the federal government that sells to the federal government. They have to sell to a Native American tribe at favored nations pricing. So that allows us to get all of our raw materials and resources for a much cheaper than the average bear. So if we put all of these together between the taxation and the acceleration of contracts and working with both private and public entities, it's a huge competitive advantage, but still the basics of conducting yourself in business and biotech still apply. This just adds to it.
You know, I'll just make a comment here, John. It's I'm listening to all of those benefits of being a legacy underserved, exploited part of the population now presents opportunities to do business in medicine with more focus on being efficient with dollars, with being efficient with our agencies who are responsible for regulation, and also where you have an efficiency of having access to people and their data. And it might be really interesting to think of how the model that you have sort of recognized and coalesced in this tribal nations approach, why couldn't we replicate that on a broader scale for all Americans? I still posit that having spent my whole career with the rare disease patient population, where there is anguish in the neglect because they are invisible in terms of their prevalence. But we all face, as Mark said, we all face some medical condition over the course of our lives and that of our loved ones. We all deserve to have access to the best knowledge, the best information, the best treatment pathways, without having to be in the privileged few who can get to the NCI, who can get to top docs here and there. This sort of democratization of access, but also to contributing to the development of all the medicines we actually need. That's how we're encouraging you, this audience, and others to think about yourself as an investor in a better future for you as a patient. So making that circle complete is really, I think, what we're trying to talk about.
If I could just add
And
one more.
may I ask John just to say, anyone in the Indian nation that needs help with cancer, send them the Cancer Commons. It's nonprofit, no
Actually,
cost. And in return, we will use all the advantages that you talked about to be able to fast track the development of not just individual drugs, but regimens, combinations of drugs. And that's what trials don't do well.
If I could actually add into that, that's
One
why I
maybe
was
things.
interested to talk to the panel after the fact, and I wish I was there physically for a whiteboard session, because I'm happy to say, and this is what brought me out from CEO of the Seminoles to go into the Native American Venture Fund and out to this portfolio company, Clear Health Pass, is in 2014, the Supreme Court redesignated Native American tribes as domestic sovereigns. And so the tribal rights aren't just limited to the boundaries of the reservation itself. It actually is bound to anywhere the Native American tribes has an economic interest. So as long as the tribe is economically tied to the project itself, their sovereignty follows, thus the rights. And I'm using this as with a big asterisk, because there's 10 plus years over of having to really understand the dichotomy of tribal rights and constitutional rights. But that's a conversation for another day. So meaning that the whole purpose of this is for all America and beyond, by leveraging what we could do within the tribe as a seed to start.
Great job. Fantastic.